from Mumbai, Dr. Jitendra Kumar Dayalal Shah from Bayad, Dr. Pradeep Patro from Chhatrapur, Dr. Ashutosh Das from Tamluk, Dr. Shashi Khare from Bhopal, Dr. Umesh Khopkar from Mumbai, Dr. Sanjeev Puri from Hoshiarpur, Dr. Surjit Kalsi from Noida, Dr. Akshay Mothe from Bodwad, Maharashtra, Dr. Ashwini Kumar from Kanpur, and Dr. Devraj Bhai Dolaria from Surat. So I would like to thank all the doctors to take part in our quiz. Now, to enlighten us regarding today's topic, I would like to welcome Dr. Sanjay Kalra, Chairperson of Education Working Group, International Society of Endocrinology, and past President of South Asian Federation of Endocrinology. Over to you, sir.
Thank you, Ankur, and good evening, everyone. As always, it's a pleasure being part of FDC Diabetes Essentials. And we look forward today to a special guest, Professor Nitin Kapoor, who will be speaking to us about how to manage weight in diabetes. But before that, we see many questions. Allow us to take them first. Thank you, Dr. Vinay Desai, sir, for being with us. So his question is, a 50-year-old gentleman weighing 50 kg is on 30 units of premixed insulin, 20 in the morning and 10 with dinner. He gets hypo in the morning. Okay. So the hypo in the morning is because of the nighttime dose. So let's see the things we can do. Make sure that the dinner is adequate. Make sure that the patient takes a late night snack. Just before going to bed, the patient can take one biscuit or a glass of milk or maybe some fruit. If the patient gets up in the middle of the night to maybe to go to the bathroom, there's many people are used to that. The patient can keep a small amount of fruit or biscuit near his bedhead, near his pillow, and take that. All these will prevent the early morning hypo. If you feel that all this is already optimized, then we reduce the dose of the dinner insulin. That is, instead of 10, you make it 8 or 7 or 6. Once you do this, things are fine. The morning dose should be given. The question is, should I give the morning dose or not? Yes, because that will cover the next 12 hours. So basically what you do in premixed insulin, you check 2 glucose levels first. Before breakfast, that will define the dose that should be given before dinner. Then you check the before dinner dose. That will define the dose that you should give before breakfast. So you check the glucose now, but you take action the next day. Once these pre-breakfast and pre-dinner glucose levels are taken care of, then we can actually move on to looking at postprandial glucose and trying to optimize the dose. So do give the morning dose. And for the night, we said add a snack, make sure that dinner is adequate, and reduce dose if required. In such a patient who is 50 years old gentleman and weighing only 50 kg, the patient may have pancreatic diabetes actually, and glucagon levels may be low. And that is why perhaps hypoglycemia is occurring at such a low dose, because you don't have glucagon, which is a counter-regulatory hormone. So ask the patient for symptoms of abdominal pain, diarrhea, steatorrhea. Look for signs of malnutrition, especially micronutrient, fat-soluble vitamin malnutrition. And these will be markers towards thinking about pancreatic diabetes. The simplest treatment would be a plain X-ray abdomen or an ultrasound abdomen to look for pancreatic stones. Another question is about thyroxine. Why some people get 2 tablets thyroxine? So this is actually a regimen which is by old timers, including me. Earlier, we used to have only 100 microgram tablet. So if you want to increase the dose, the half-life of thyroxine is quite high, quite long. And you actually count the weekly dose. So because we had only 100 microgram, and what we would do is instead of telling the patient to break it or take 1.5 tablets, 1.25 tablets every day, we would just say you take 8 or 9 tablets per week. That is how it is done. Now this regimen is becoming less common because we have doses like 112.5, 137.5, 37.5. All these doses are available. So we use precision dosing now. So basically, they are counting the dose per week, and it will be usually old-timer endocrinologists who will do that. Sometimes we want to change the dose. We want to increase or decrease, and patient says, "Sir, I have one full tablet bottle. I have 60 tablets in the bottle. So how do I finish them?" So then also you can use this regimen for short period of time. Namaskar to Dr. Devraj Dolaria from Surat, Gujarat, Dr. Anshul Singhai from Bhilai, Chhattisgarh, and Dr. Yogesh Uplenchwar. Thank you for your kind words. We also welcome Dr. Gauri Shankar and Dr. Vivek Tiwari for being with us. Okay, and Mohammad Nadeem ji has a question. We will ask Dr. Nitin Kapoor to take that. And also a question, very insightful question by Dr. Anshul Singhai on ABCD obesity model and BMI centric model, which is more relevant in India? To answer this question, and we also welcome Dr. Ermias Gebremichael from Ethiopia. To answer this question, we are very happy to welcome our speaker, Professor Nitin Kapoor. Warm welcome, Dr. Nitin.
Thank you, sir.
Professor Kapoor is consultant and head of unit at the prestigious Christian Medical College in Vellore. And he's an expert on, of course, every field of endocrinology, but especially on obesity. So, Dr. Nitin, warm welcome. Greetings to you from across the world. And what would you
Thank
like to speak about today, sir?
So thank you for the opportunity and thank you for having me here today. Uh, Today's session, we are going to talk about mainly managing weight in the presence of diabetes. And I think this is a burning issue. And it is something that is very, very common in our country. And this is what I plan to address, management of obesity in the setting of diabetes.
So, handling two diseases together, two conditions together. So, warm welcome, sir, and the stage is yours.
Thank you so much, sir. So I'll just share my screen. And so, right at the onset, I'd like to, thank again for having me here. This is indeed one of the most prestigious shows, and sharing stage with Sanjay sir is always a privilege and honor. And in this maybe 20 minutes or so, I shall take you through this topic of managing obesity and diabetes together. How do we do that? And it would be a brief presentation. Uh, are you able to see my screen? Not yet. Okay. Just give me one more minute. Okay. Is it visible now? I can see it in the backstage. Great. Yeah. So thank you. And let's start with the presentation right away. So, friends, we're talking of optimization of weight in the management of diabetes, and we'll try and address this topic by answering three simple questions. We'll be talking about why, how, and what. We'll talk about why this topic is important, how do we manage it, and what lies ahead in the future management of diabetes and obesity. So, I think it's not something new that we are talking about when we say that obesity has reached pandemic proportions globally. We've come across a COVID pandemic, but when we look at the numbers for obesity per se, globally, it is definitely much, much more. And even in the Indian setting, when we looked at data from the National Family Health Survey per se, we found that about 35 to 40% of the Indian population had overweight or obesity. So this was data from the National Family Health Survey 4. But when we look at National Family Health Survey 5 data, this data, which was in the late 30s, has jumped to early 40s in just a span of 5 years. So definitely obesity is a big problem. And again, when we looked at data from Vellore here itself, we know from the Vellore birth cohort, we've seen that the prevalence has jumped from 30 to 70% in women over the last decade. And it's not spared any age group. We've looked at school children, we've looked at elderly postmenopausal women. And the fact remains, yes, that obesity is definitely a big problem. And today, in clinical practice, we do have patients who walk into our clinics and ask, Dr. Saab, we need to lose weight. And so, how do we do that? So I would still like to show this article which Dr. Kalra had authored way back in 2013, and that kind of vision to have that today we would need physicians who would actually address diabetes and obesity together. And that's why this particular talk is important. This topic is important. But when we talk in terms of diabetes and obesity together, and especially from an Indian paradox, we see that the prevalence of diabetes is definitely one of the highest, not only just because of the sheer numbers, but also because the number, the frequency of people. We are about maybe 100 people watching this show right now, and one out of 5, 1 out of 6, or in some cities, even 1 out of 4 people would have diabetes. But when we look at this in light of obesity, we see there is a little bit of a paradox here. We see that despite having a large proportion of people with diabetes, the proportion of people with obesity isn't that much. And for that, we need to understand a little bit more about this concept of obesity within our country, or something that's more specific to our population. And this is the concept where, despite having people with normal BMI, we may have people who may have high body fat. And if we just look at BMI, it doesn't help us answer all the questions. But rather, if we look at body fat together with BMI, we have this unique cohort of patients which are called as normal weight obesity. So, friends, today we're talking about diabetes and obesity, but at the same time, I'd like to highlight this specific phenotype where people may have high amount of body fat despite normal BMI. And so, the actual problem of obesity that we're dealing in patients with diabetes is much, much more. And as you can see in the slide, the definition of people with normal weight obesity would be anybody who's got a low BMI, less than 25, but high body fat. And this is really, really common in our setting. This is another study that we were involved with. We see that about 30%. So earlier I was saying that 1 in 5 of us listening will have diabetes, but I'm talking of 1 in 3 would have normal BMI but high body fat. Another 1 in 3 would have high BMI itself. So practically, we are trying to say that majority of the population will require some kind of attention for obesity, and with diabetes, it becomes double trouble, because even these people with normal weight obesity tend to have much higher body fat and higher complications of diabetes, hypertension, and dyslipidemia. And therefore, definitely intervention is required. And yes, lifestyle intervention is important, but at the same time, we need to make sure that this is started at a very young age, and maybe much earlier than before even diabetes sets in. So I think we'll directly go on to this important aspect of how we are going to manage this particular problem when we have diabetes and obesity together. And when we are looking at this guidelines which are available for management of obesity, they have changed over time. Earlier, we were all talking of BMI centric guidelines, but today it's all become complication centric. And when it is together with diabetes, and we see these two guidelines which came up from India in the last 2 years, which is both for management of obesity and for management of diabetes, I think they go hand in hand. So, friends, I'm going to present to you a simple framework that you can use in your clinical practice that can help you manage diabetes and obesity, and especially handle obesity in presence of diabetes. And this is something that was initially proposed by the Canadian Obesity Network, the 5A framework. It's a very simple framework, but I think it really helps in clinical practice. It's easy to use. I'll take you through this framework one by one. And the first A that we are talking here is ask. So when your patient with diabetes walks into your clinic and is wanting to lose weight, patient has obesity, I think the first responsibility of us as physicians is to ask the patient whether the patient is okay to discuss weight. Yes, if the patient themselves come and tell you that, doctor, we want to lose weight, yes, that's fine. But again, still, I think that assessment to uh, try and assess whether our patient is willing to lose weight or not is very important. Many times, in practice, what it would be is that either a spouse or a parent or a sibling or somebody else has really got the patient to you and saying, "Doctor, isko weight kam karna. You need to, do something to help this patient reduce weight." But if that patient per se is not interested to lose weight, then it's difficult road ahead. So I think the first important thing is to try and assess the willingness of our patient, whether they're able to lose weight or not. We don't have to be judgmental. We have to make sure our environment in the clinic is very, very weight friendly. We have to be very careful of the words that we choose for weight loss, and not kind of have any kind of stigma or discrimination against these patients. We shouldn't be using words like heaviness, obesity, large size, excessive fat, These are all discriminatory kind of words. And this is another study that we had done recently here in Vellore, looking at how the stigma really has an impact on patients with obesity, because it's not only that people with obesity are stigmatized in the society, but stigma per se, especially in the study we found, also has a bidirectional impact, which can kind of affect or increase the chance of obesity, poor dietary choices, and even to the extent of developing psychiatric problems, and suicide risk also increases. So we are seeing stigma and obesity as a bi-directional problem. So friends, that's why I'm emphasizing that when your patient with diabetes comes to you for weight management, it is very important to ask willingness of that patient to whether he's willing to change weight or not. But at the same time, we ask in a very scientific way, in a non-stigmatizing way, and that is the first A of the 5A framework. Let's look at the second A, which is essentially to assess. And when I talk of assessment, I think there are three things that I have to assess here. I have to assess the severity of obesity. How severe is the obesity in my given patient with diabetes? That's the first part of the assessment. I also have to assess the other comorbidities. When my patient already has diabetes and obesity, I need to make sure what are the other comorbidities that my patient has. And the third thing that we really need to assess is to try and assess some kind of root cause of obesity in that given patient, because the root cause of obesity may be actually different for different patients. So let's look at these three small aspects of assessment. The first assessment I said is to assess how severe is the obesity in our patient, and one of the best ways is using one of these anthropometric markers. But over the years, definitely the trend of using just specific anthropometric markers, especially BMI, is not often recommended. So BMI is not recommended as a stone alone indicator for obesity because of several problems. Though yes, we all use it. It is easy to use, but as I mentioned before in my presentation about the concept of normal weight obesity, where we may miss people who have obesity or high fat despite having a normal BMI. So today, an easy way to assess obesity is not just by looking at numbers, but try and stage obesity with the help of staging systems. And this is one simple staging system that we often talk about, called the Edmonton Obesity Staging System, where you would stage people from 0 to 4 based on their medical, mental, and functional abnormalities. Now, why am I talking about this specific staging system? And I would say this is essentially because in this particular study that you see, they followed up patients from the MAINS database they've looked at for over 15 years. And you see how on the left hand side, BMI does not seem to predict mortality, but Edmonton Obesity Staging System is able to predict mortality much, much better. Anybody with a your stage of more than 2 is likely to have significantly higher mortality. Now, again, when we looked at data from our own obesity clinic here in Vellore, we found that a majority of our patients actually fall in stage 2 and 3. So, friends, that is the first part of the assessment that I wanted to say. So, when your patient has come, you've asked the patient their willingness to lose weight or not. I think the second A that we're talking about is assessment. And the first part of assessment is you have to assess the severity of obesity. Yes, you can use all the anthropometric indicators which are available, but I think you should be able to stage the patient irrespective of the BMI. Try and understand how severely the patient is being impacted by obesity. A patient who's come on a wheelchair because of osteoarthritis of the knee would directly be at a much later stage than somebody who is maybe much more heavier, much higher weight than this patient, but has no medical, mental, or any kind of mechanical issues with obesity. So that was the first part of assessment. The second part of assessment is to try and find out why my patient has obesity. Well, they have diabetes, and often patients do come and ask us why they have diabetes. We tell it could be genetic, could be your lifestyle. Very similar for weight gain as well. It could be because of slow metabolism, it could be because of diet, it could be because of lack of activity. But friends, the point that I'd really like to stretch here is that it is important to try and find out the root cause in that given patient, and it is different for different patients. So at times I may have a patient who's taking medicines, say for epilepsy or some disorder which is increasing weight. So for that patient, I think I need to address that problem. Whereas for another patient, it might be more of an issue with diet. For sometimes it is exercise. So excuse me, depending on the root cause of obesity that we identify for a given patient, I think it's important to target that. So that's the second part of assessment. The third part of assessment that we talk about is to try and assess the comorbidities. I think all of us, especially if the patient has diabetes, will be able to assess all the metabolic problems. But what we should not forget is the mental and the mechanical problems of obesity. Now, these are often ignored in clinical practice. Especially, I'd like to highlight the mechanical problems and the mental problems. So, mechanical problems like osteoarthritis, sleep apnea, believe me, if these are addressed well, your patient's quality of life will improve a lot. But when we talk of the mental problems, and this is again data from our clinic where we found that about 30% of patients who actually walk into our clinic have an underlying psychological problem that needs to be assessed. So, friends, this was the second A of the 5A framework. The first A that I mentioned was to ask the patient their willingness to lose weight. And again, I'll remind that it has to be asked in a most sensitive way, which is not stigmatizing. The second A that we are talking about is assessment. Assessment of the severity of obesity, assessment of the root cause of obesity, and assess the comorbidities associated with obesity. And this takes me to the third aspect of the 5A framework, which is the advice that you have to give. I think this is something very, very important of all the 5As. What advice you're going to give your patient with diabetes, with obesity. So, yes, we do talk about general principles of a more disciplined life, right from adequate sleep to time management. Dietary interventions, well, when you talk of diabetes with obesity, and this is a consensus guideline that even Dr. Khaldas spearheaded a couple of years ago. And I think the key factors that came out of this guideline was that definitely we have to, advise our patients to eat on time, not to skip meals, not get so hungry that, by the time they are about to eat their next meal, they're probably eating twice or thrice the amount that they have to. The oil intake in the house has to be looked into, and overall, whatever dietary prescriptions we give should be sustainable long term, should not impair the quality of life. And I think from our setting, again, improving the protein intake is something very, very important. So this is a simple three-step way of trying to assess and prescribe the diet for a patient with diabetes and obesity. And I would say it is best to try and first just change the proportions of the foods that are commonly made in that particular household rather than bringing a totally new diet, which at times, yes, patients are willing to follow. But if you're looking at sustainability, that may not work out. So again, trying to give a stepwise approach is very, very important. Trying to first maybe understand what the patient is following at home, then try and advising, giving advice which is patient centric. And as I said, the first step is often just, if they're making dal and rice, just reduce the rice, double the dal, triple the dal, improve the protein, reduce the carbs, reduce the fat, and changing proportions within the same diet, which is commonly cooked, is one successful way to begin with. And definitely, these patients would require long term follow up. So, yes, in the advice, dietary interventions are important. As long as physical activity is concerned, I think if I just have to show one slide, I think to try and explain our patients the mismatch that often happens between diet and exercise is something that we can often just tell them. So, an average portion of French fries, I think most of my patients would have had, and just trying to, give them an understanding the quantum of exercise that is required for any of consumption of this moderate French fries is so much. Whether it's 1.5 hours of swimming, or 3 hours of walking, or 2 hours of bicycling. I'm sure none of us think in this way. So I think if our patient understands the mismatch between diet and exercise, they will be able to handle their physical activity and control the diet much, much better. And again, there's a stepwise process of when you prescribe physical activity in patients with diabetes and obesity. It starts with flexibility enhancement, balance training, aerobic exercises, and resistance at the end. Apart from physical activity, are there other things? Yes, intensive behavioral therapy is something very, very important. And this is something, again, that I've learned from Dr. Kalrasa, talking about a MOC model. So, what is this about intensive behavioral therapy? And I think this is one reason why, when you're managing patients with diabetes and obesity in clinical practice, really, really helpful to bring in these psychological interventions, simple tips that you can provide through intensive behavioral therapy go in a long way. And maybe one example that I will cite, that again I saw my psychiatrist telling in the pediatric clinic yesterday, for a child with obesity who had, really struggling with weight. And he said, "What do you do when you get your results or you're successful in an exam?" They say, "We party, we go out for dinner." So just changing that dinner to maybe a movie was one suggestion given. And trying to give motivate the patient that yes, it's important to celebrate, but at the same time, provide an opportunity, give an option to the patient to follow something which is not going to increase the weight, and then try and assess the capability of that patient to follow that particular example. And this is a very simple model. Again, behavioral therapy is something very effective, often underutilized in the management of obesity with diabetes, and I think should be emphasized. Briefly talking about meal replacements. So, what are meal replacements? These are all endorsed by all national guidelines, including the Endocrine Society of India guidelines. And the basic concept of meal replacement is that any one meal in a day you may replace with a supplement that is available in the market. And when you supplement this meal, or rather replace the meal with this meal supplement, you're going to provide very low calories, often to the scale of 150 calories, which is 20 grams protein. And this gives patients adequate satiety. With 150 calories in a meal, they lose weight. But the biggest advantage of these, meal replacements is that it also takes care of all the micronutrients cover. If I'm giving my patient a very low calorie diet, in a month they would come back and say, "Doctor, I'm having hair fall, my nails are becoming brittle, my memory is going." So I don't want those kind of symptoms. And again, if you address the micronutrients, this is helpful. You can see on the slide the indications when these formula MNTs should be used. So yes, this is another important aspect of giving advice. Talking about medications, yes, before talking of all the good high-end anti-obesity medications which are in the pipeline, I think a more basic step is to try and address the medicines that the patient is already taking for, not for obesity, but for their comorbidities. And you try and see which of these medicines are actually increasing weight. So if you can choose the weight neutral or the weight losing, simple example again I'll give of diabetes. When these patients with obesity and diabetes, if my patient is on sulfonylurea, I would like to change that to either an SGLT2 or at least a weight neutral DPP4. So just tweaking the medicines for the comorbidities also assist in weight loss, and obviously the pharmacological interventions can follow. We don't have really many drugs at this point. I will talk about the newer medicines in a while, but I think till the time they are available in India, we still have to depend a lot on what we are already using is lifestyle, intensive behavioral medications, meal replacements, using changing medicines for the comorbidities. For diabetes, if my patient is on weight gaining drugs, maybe change over to GLP-1 RS if the patient can afford. Now, liraglutide is off patent and is affordable for many patients. If medications don't work, can we use bariatric surgery, especially in the patients with diabetes? Again, yes, in the presence of diabetes, the indication for bariatric surgery in the Indian setting would be 32.5 kilogram per meter square. Again, this should be done in the setting of a multidisciplinary clinic when you are able to have many patients, going through all the clinic we assess and we've tried adequate lifestyle. I think that's when we should be advising bariatric surgery. And this is another aspect of intragastric balloon which can be used. So this is not like a surgery. This is something which is removable, and we've been doing in Vellore, and now we've also started intragastric suturing, which is another important way of losing weight. So these intragastric procedures cause weight loss to the scale of 15 kgs. The balloon can be removed after a year, and thereafter the patient can be put on a weight maintenance diet. So when we're talking of management advice of patients with obesity and diabetes, I think these were the important aspects that I thought I would cover. The last two aspects of the 5A framework, the fourth one is to agree. Again, as I said, the guidelines have moved from what was a complication or BMI centric approach to a patient centric approach. I think the patient has to be a part of your plan very well. You have to make sure your goals are in line. The patient should be able to, kind of relate to those goals. Sometimes in practice, I would say that patient, if okay, next time we are able to achieve, maybe this lipid profile to be this much, or if you're really reducing your oil, I'm sure your triglyceride will come down. I'll try and reduce this medicine. So I'm giving patient a particular goal. I give it in a time frame, and I also reward it. Patients would be really happy to get rid of a medicine if you are able to give them a goal, and that sometimes really helps again in clinical practice to lose weight. The last aspect is A for assessed, and I think the only message that I would like you to follow here is that we have to treat obesity like a chronic disease. It's not like we've got good weight loss today in 3 months and that's the end of the story. Like any chronic disease, in the presence of diabetes, the way we manage diabetes, I get a normal HbA1c. I don't say you stop everything and go back home. These patients need lifelong follow-up, lifelong changes in medicines, and I think obesity also needs to be handled in a similar way. Long-term follow-up adherence is the key when you're talking of management of weight in the setting of diabetes. So I think I've already talked about how we manage. In the last aspect of the talk, I thought I'll just take you to the newer aspects of what we have in terms of obesity management. There's a lot of research, a lot of news in the market about what these newer drugs are going to be. And this is another article spearheaded by Dr. Kalrasa on GLP-1 RAs and how these drugs are used both for diabetes and weight reduction. The first trial that actually showed this remarkable effect on obesity was the step one trial with semaglutide injection, and it showed about 15% weight loss. So that was something that has got this drug an approval for management even without diabetes. We in India do not have injectable semaglutide yet, but we have oral semaglutide. The weight loss with that medicine is about 5%, not 15%, but yes, 5% is also very, very effective. When you look at the different step trials, now there are four of them that I'm showing in the slide, but close to 17 step trials have already been published, and the quantum of weight loss is huge. After semaglutide, I think we've got tirzepatide as another drug, which is a triple agonist of GLP, double agonist of GLP and GIP. And the quantum of weight loss is to the scale of 21%. Many times patients would ask doctor how long they have to continue these drugs when they're available in India. The answer is it is lifelong. Like we manage any chronic disease, these drugs also need to be managed. But this is actually first time in the history of anti-obesity treatment that we have drugs which respond so well. And as I said, tirzepatide causes weight loss of 21% and probably will be launched in India in the next year or so. Another important drug which is picking up a lot of news is a combination of semaglutide with cagrilinotide. What is cagrilinotide? That is essentially an analog of pramlintide. So it's an amylin analog. Again, weight loss to the scale of 15 to 20%. Apart from this, what else is new in the field of obesity? I would say that is also something that is coming up is genetics. So even monogenic causes. And again, I think this is something more relevant to our setting in India, where we have a lot of consanguineous marriages that still happen. And again, now with much cheaper genetic testing with the help of NGS, we are able to do tests for monogenic panel. So when we have to do these tests in people who have got young onset obesity, history of consanguinity, young onset severe obesity, or family history of severe obesity, or associated with mental retardation and other telltale signs of specific disorders. So why is it important? Because now again we are having these newer drugs that are specific for people who have these mutations, and I think That's where this is helpful. So, friends, I think with this brief presentation on management of obesity and diabetes, I would come to my key take home messages. As I said, both diabetes and obesity are very, very common problems in our country. I spoke about this 5A framework, which is a simple framework that can be applied in any clinical practice. When you have a patient with obesity and diabetes in front of you, just go with that framework, ask the patient willingness to lose weight, assess their severity of obesity, the cause of obesity, and the comorbidities that the patient has, give the advice in a stepwise manner. That's something that the patient can follow. Ask them about whether they can agree and to the goals that you have set for them, and last but not the least, also assess them for a long-term follow-up. I also specifically mentioned about assessment of obesity. Go away from BMI, try and use clinical staging systems, and talked about the newer drugs and the genetics of obesity. So friends, with this, I will stop here, but I would be happy to interact for any questions. Over to Kara, sir.
Thank you, Professor Nitin, and lots of comments coming in for you. Dr. Sanjay Marathe says, beautiful discourse, and I agree with Dr. Sanjay. Good evening to you, Dr. Nitin, from Dr. Lambe as well. And Dr. Gauri Shankar has a challenging case. A 62-year-old lady weighing only 40 kg. HB1C is 10.5, and she's on Mixtard 10 units at night. She has dry mouth as symptoms. A1C is 10.5, but also she has early morning giddiness. So what should we do with this patient?
So
How should we
I
change the
think
regimen?
Right. So I think a lot of things we can correlate in this patient is because of the hyperglycemia. Right from dry mouth, you also mentioned the weight is 40 kgs. Maybe the patient has lost a lot of weight because of the hyperglycemia that has been there. So I think we have to get the glucose under control. Now, giving once a day premixed insulin is something that is, I feel, may not be appropriate. I think the first step here would be to ask for a good self-monitoring of blood glucose. I'd like to see at least, four glucose values if my patient can check and come back with that. And if my patient is having giddiness in the morning, if the fasting is low, I would like to probably, reduce the night dose of that long-acting insulin, but try and address the postprandial peaks that the patient might be having, which has contributed to the high A1C. And I must also educate my patient that if the A1C is 10.5 and I've started more intense control, patient may still feel weak because they have been used to very high glucose. This in scientific terms would be called as relative hypoglycemia. So they may feel weak, but they should monitor. And if the glucose values are within the normal range, we tell them not to worry. In a few weeks' time, they will adjust to the normal glucose and we gradually bring it to normal. But I would attribute most of the symptoms of this patient to the high glucose and correct that.
At the very least, premix twice a day, but ideally, if we could convince the patient to take basal bolus, total units will be just around 20 or so. But if you can divide into 4 doses, the patient will feel much better. Dr. Anshul Singh asks if there is any good guideline on management of diabetes and obesity, nutritional management. Any consensus that you have?
Sure. So I showed that slide. I think now that you know, so this was published in the Journal of Diabetes, Obesity and Metabolism in 2019. Dr. Kalrasa had spearheaded that. It is called the Komen Guidelines. I can put it in the chat box as the link. You can see that. Yeah.
Dr. Gauri Shankar has another case, 52-year-old lady with random glucose of 350 with severe gastritis, and she also complains of daytime drowsiness. So let us take this in 3 parts. How do we manage the random glucose 350? Second is what do we do for the gastritis? And third is what are the possible causes of daytime drowsiness in a 50-year-old lady? What is happening at night? How does the night contribute to daytime sleepiness?
Absolutely. So I think again these might be sometimes related. So when my patient has a high glucose, this needs to be addressed again by more frequent monitoring. Uh, the point of daytime drowsiness again sometimes could be related to hypoglycemia, especially if the patient gets onto a premixed regime. They may have hypoglycemia if they're not really following a three meal kind of three snack pattern. So what happens is with this insulin, they have a peak, but then they may have a low 2 hours after the meal. So again, giving that 3 meal, 3 snack. But again, the baseline would be more frequent monitoring, trying to assess the glucose, trying to make the insulin more, specifically targeted to the glucose values which are high. Sorry, sir, I missed the third point. One was the drowsiness, one was the high glucose.
And the third was gastritis.
Gastritis. So again, I'd be very careful here when I use oral antidiabetic agents because some of them can cause gastritis. So if my patient is on high doses of metformin, which are not sustained release, or if my patient is on DPP-4 or GLP-1, I would like to reduce them. Try and use more gastric friendly anti-diabetic agents. Drugs like maybe sulfonylureas here are relatively okay with the stomach. Even if I need to use an insulin sensitizer, pioglitazone is not very bad with the stomach. So avoiding Voglibos, avoiding GLP-1 RS, and if the patient is on a high dose of metformin, I reduce the dose, make it more sustained release, and I think that is something that will also reduce these symptoms.
Dr. Armias from Addis Ababa says that it's always difficult to manage weight in obese diabetics, especially if they're on insulin. And we agree, actually, it is quite challenging. Like Dr. Nitin said, you have to bring out all the tips and tricks from your cupboard to manage that. Dr. Singh asks if we have any cost-effective GLP-1 RA for T2D and
Right.
obesity in India. What is the most economical GLP-1 RA right now?
Right. So at this point, what we have in India is liraglutide. So till 3 4 months ago, it was available as a patented drug. So even zero point 0.6 mg that we were using would cost around 5,000. But off late, it is off patent. I know about at least 3 companies which have already marketed or in the process of marketing injectable liraglutide. So instead of 5,000, it is now around 1,200 to 1,300 rupees per month for zero point 0.6 mg. So yes, there are options of cheaper GLP-1 RAs in India now.
So generic liraglutide is available in the country and it's working well. Dr. Gauri Shankar shares an unfortunate incident. He had a 42-year-old lady who was given iron sucrose injection. The first dose was okay. Second day, suddenly she had chest pain and she died. So actually, unfortunately, iron sucrose is associated with a high risk of such unfortunate incidents. So it's an allergic reaction. You don't even know the reason for it. But instead of iron sucrose, actually the FCM, ferric carboxymaltose, is a safer drug. So maybe in future, sir, we can try ferric carboxymaltose. Earlier, FCM used to be quite expensive, but now as multiple companies are marketing, that cost has also come down. You have to give intravenous and you have to finish within 15 minutes. If you keep it too long, then also you get in trouble. If you give it too fast, also you get in trouble. So you have to time the IV infusion properly. Dr. Anshul asks about metformin in people without diabetes with obesity. What is the status?
Right. So in my practice, I would use metformin only if my patient has at least pre-diabetes or diabetes. So without diabetes, not recommended. The quantum of weight loss also is minimal. So with at least pre-diabetes.
Should metformin be continued if a lady becomes pregnant? The patient in question is obese, has diabetes, and she's already been on metformin. Now she has got a UPT positive. So should we continue in first, second, third trimester?
Right. So yes, if my patient is already on, they do continue metformin. The only concern had come when the studies showed that if the patient is on metformin in the first trimester, it may have certain changes in body composition, maybe 8 to 10 years down the line for the child. But for that reason, as of now, the guidelines would say that if the patient is not on, I don't start in the first trimester. Later, I can. But if the patient has already been on, we do continue. In my practice, we continue.
One, Dr. VK Goel has joined the meeting. So warm welcome, Dr. Goel, sir. And Dr. Gauri Shankar asks, what is the reason for postural imbalance in people with diabetes? So why does autonomic neuropathy occur? And then how do we treat it? That, of course, is a very difficult question, but Dr. Nitin is the perfect person to answer that.
Right. So sometimes it is really, really challenging. It's not only postural giddiness. It could be resting tachycardia. It could be bowel-related symptoms, bladder-related symptoms, autonomic neuropathy associated with high risk of cardiac death. So definitely this has to be taken seriously. I think the first step is to try and understand how much is the severity of autonomic neuropathy. And if you have the facility of AFTs or autonomic function test, we can do it. But otherwise, I think the first step is to make sure the glycemic control is good. Second, if the patient is having giddiness, postural drop, simple tips of, when they change posture, do it slowly to keep themselves hydrated, take their medicines on time, and avoid other precipitating factors like hypoglycemia or dehydration. So these are simple tips that help. If not helping, then sometimes we end up using drugs like fluorocortisone and Utodrine, which is not commonly available. But yeah, it's not an easy thing to handle. But yes, if you improve glycemic control, these simple measures help quite a lot.
Would it make sense in selected patients to use fluorocortisone in very low doses for
Yes, sir.
autonomic?
I mentioned that yes, we use it, and again, you have to be mindful of the electrolyte follow up. But yes, we use it here in Vellore also.
So fluorocortisone half tablet usually, maybe one tablet. That would be another treatment that we can try. Uh, Dr. Anshul says in an obese person with diabetes with depression, so diabetes, depression, and obesity together, what would be a safe antidepressant? What are the drugs that you use frequently?
So most of the anti-diabetic agents, antidepressants, cause hyperglycemia. Very small doses, sometimes of metazapine. I've been using. Yes, it does increase the glucose or the weight a little bit, but what is available in India is 7.5 mg. I would use it like quarter tablet, not even half, but even quarter. Sometimes it gives good results. Yes, if my patient has neuropathy, peripheral neuropathy, adding on drugs like amitriptyline also helps to handle both the situations. But still, I think I do emphasize on three things, which are not drugs, but people who are having insomnia in diabetes. And the three things that I tell them is to make sure you have your dinner early, not a very late dinner. To make sure you walk a little bit, even if it's within the house, but after minutes is helpful. And third, avoid screen after dinner. You read a book, you read a newspaper, but avoid watching screen. And most patients do come back and tell me, doctor, this worked. And yes, medicines are there, but gradually become used to. You have to increase the dose. But these are the three tips I would still say are better than medicines.
Thank you. That was really insightful. Dr. Anshul says from an obesity window, from a weight gain perspective, is there a difference between gabapentin and pregabalin? Because we know that pregabalin can cause edema, and that can present as a false weight gain. But is there a difference in both of them, these drugs, gabapentin,
I'm not
pregabalin?
really aware of a head-to-head comparison with respect to weight, apart from the mechanism as I described. I don't see it so much difference in clinical practice. In terms, it's probably just a little bit of edema, but not really big quantums of weight that we're talking of.
Dr. Siddharth Dhangar from Mathura has joined us. He's a dynamic diabetologist there. And Dr. Gauri Shankar shares one of his pain points. 65-year-old lady with very low BMI, weight only 35 to 40 kg. So are these type 1 diabetes or type 2 diabetes? At age 60-65, but the BMI is very low and weight is less than 40 kg. What would be the regimen of choice in such a patient?
Right. So I think in the elderly, apart from I wouldn't think so much of type 1 diabetes. Though just last 2 weeks ago, we had a patient first time diagnosed type 2 at the age of 61, but that's rare. So here I'm probably looking at low weight because of malabsorption, because of sarcopenia, because of poor glycemic control itself. And I think addressing that is important for such patients with very low weight. I think insulin is the way forward. If I'm able to improve their glycemic control, there might be better weight gain. But at the same time, addressing sarcopenia in them, low muscle mass, by improving the protein intake, resistance exercise, I think that's another important thing to be looked into.
From Karnataka, a query. Uh, do you recommend vaccination to all your adult patients with diabetes? What is the practice that you follow in your OPD currently?
Right. So we have a very good system in place. So we have 16 diabetes educators in our department. And so before the patient actually comes to me, the patient is already given a slip for vaccination. We do offer vaccination for hepatitis B and pneumovac to all new patients of diabetes who come to our clinic. So we do give.
One question on fasting from obesity, from an obesity perspective. So Dr. Gebre Michel says, does fasting influence obesity management? Let's structure our answer in obese people without diabetes or obese people with diabetes. So does fasting have an impact? If so, what type of fasting would you suggest?
Right. So I'm not a big fan of fasting, especially in people with diabetes, because especially if they are on drugs that cause hypoglycemia, that will cause more harm than good. Uh, in people without diabetes, again, if the fasting is followed as a protocol like an intermittent fasting, where they fast for minimum, let's say at least 15 hours or 14 hours, yes, then you are going to burn more fat, get into a bit of ketone production, and lose weight. But again, I don't recommend that very commonly in my clinical practice, because again, sustainability is the more important question here. If my patient is able to follow it for some days but does not do it long term, it's a problem. So overall, not a big fan of fasting in people with diabetes, in people with obesity also, only if they are able to do long term. That's one type of fasting, but there is other religious kind of fasting that people often want to do. And again, we have to be mindful of the drugs that they are on, especially in diabetes. Change it in a way that they don't develop hypoglycemia, which is a concern.
Dr. Anshul has a long question, so let's take it one by one. When it comes to drugs for lipids, does it make a difference in our choice of statin, whether the patient is obese or not, whether the patient has type 2 diabetes or not?
Correct. So, not in my practice. We use whichever statin, rosustatin or atorvastatin is available. Cost makes a difference. The dose is different, definitely. Rosustatin more potent. So, if somebody is on 10 atorva, that patient might just require 5 milligrams of rosustatin. But per se, from weight perspective, I don't have any difference.
Yeah, so the for lipids, there will be multiple factors, but body weight and dysglycemia are not factors. Even for statins, you don't need to worry. Uh, Now, the other question is for blood pressure. For blood pressure lowering, the first line therapy, does that, is there a difference there? A person who is obese, a person who has diabetes, a person who is not obese and does not have diabetes, would our first line antihypertensive change?
Right. So this is a very practical question, and if you remember, I had showed in the slide. When we have comorbidities with obesity, which anti-hypertensive we have to use. So we know that calcium channel blockers do cause some amount of edema and weight gain. So that is something that I have to keep in mind. In people with diabetes, especially with microalbuminuria, early stage of nephropathy, I would definitely be more keen to use ARB, and but still my bottom line, irrespective of the choice of antihypertensive, would be to make sure I maintain the blood pressure in the target range, than depend on the kind of antihypertensive. So overall it doesn't matter so much. Yes, if there is a cardiac disease, I will make sure the patient is on a beta blocker. The patient has diabetic nephropathy or microalbuminuria, will make sure they are on ARB or ACE. Otherwise, combination. The bottom line is the blood pressure should be under control. The choice doesn't matter so much.
And so this gastritis not responding to pantoprazole, rabeprazole, first point is it may not be acid peptic disease. It may be something else. So it can be hiatus hernia. It can be a helminthic infection, protozoal infection. It might be lactose intolerance. Maybe diabetic gastroparesis. Perhaps drug-induced an issue like with metformin. So these are the multiple issues. How to treat one drug that we can add to the PPIs and to H2 agonists is called rebabimide. Ribagen is the trade name, and that will it's a cytoprotective drug that will actually do wonders. This question, Dr. Gauri Shankar, allow us to take next time. When can we switch from insulin to OADs? Because this will be a long question. And when should we continue with insulin at HbA1c 7 or 8? When should we shift to OADs? Allow us to take that later on. One question Dr. Singhai has for you. This is, you said that GLP-1 RA can be used to manage diabetes and obesity both. What is the checklist? What are the absolute contraindications for starting GLP-1 RA? And supposing I have put my patient on GLP-1 RA for a long period of time, maybe lifelong, what is the monitoring that I have to do every few months?
It's a very, very important question. So, I think for GLP-1 RAs, absolute no's would be only if the patient has had some kind of pancreatitis in the past, or if the patient has family history of medullary thyroid cancer. I think these are the only two which comes as absolute contraindications. Having said that, I must emphasize that MTC has not been reported in human studies. It's only been in mice studies that we talk about. Again, the physiology is different in rat models, but these are the only two absolute contraindications. The biggest limiting factor in clinical practice or even in clinical trials now that we've used tirzepatide, semaglutide, retatrutide, all of these drugs is the tolerability. My patient should be able to manage this without getting very nauseous or the GI symptoms are the major limiting factor. Now, once the patient has been started on GLP-1 RAs, and when we monitor, again, this I'm talking less from clinical practice, but more from my clinical trial experience. I had patients who've lost 15, 20 kgs. I think one important thing that we have to do is we have to reduce their oral anti-diabetic agents. Otherwise, they go into terrible hypoglycemia. Sometimes you have to do it preemptively. If my patient is coming back after 3 months and I expect them to lose 5 to 7 kgs, I make sure that at least 20 to 30% of their oral anti-diabetic agent dose is reduced. Apart from that, I think monitoring of all their metabolic parameters as per standard of care is required, uh, and nothing special. So I wouldn't really do a calcitonin and amylase every time when they're coming, only as part of clinical trials, but not really recommended in clinical practice.
So the normal renal testing HbA1c that you would do for any of the patient, exactly same for GLP-1 RA. Dr. Shashi Khare says, do GLP-1 RAs reduce fasting glucose or postprandial or both? And can we differentiate between the short-acting and the long-acting GLP-1 RA in this regard?
Sure, I think a very, very good question. So, yes, classically, GLP-1 RAs we know are based on incretin physiology, which is predominantly for postprandial control. But given the newer GLP-1 RAs, which cause so much of weight loss, so, with the weight loss improves, there's improvement in insulin sensitivity. So, the hepatic glucose production also comes down. So, you would see reduction in fasting glucose once the patient has achieved glucose. But initially, it would be predominantly postprandial glucose control. So, yes, ultimately it may become both. You're talking about short acting versus long acting. Definitely the long acting ones have been what we have been using, and they are more potent in terms of as compared to short acting like liraglutide, which is daily. So the quantum of weight loss is 3 to 5 kgs, whereas injectable semaglutide would be 15 kgs. So the efficacy here is different.
One other way of managing diabetes and obesity, Dr. Shashi Khare, is to use a fixed ratio combination of GLP-1 RA and basal insulin. So, two drugs in the country. One is IDEG-Lira, which is a combination of degludec and liraglutide. This is slightly on the expensive side and is available in select cities in the country. The other one, which is much cheaper and will be released in a week or so, this is Iglar Lixi, which is glargine plus lixisenatide. So one injection to be taken up to 60 minutes before breakfast. Uh, it's a 3:1 ratio, so you can start with maybe like 15 units of glargine plus 5 microgram, 15 units of glargine plus 5 microgram of lixisenatide dose, and you can up titrate until a maximum of 60 units glargine and 20 microgram lixisenatide. This will be once a day injection. The GLP-1 RA, which is lixisenatide, will reduce postprandial glucose. The glargine will reduce fasting glucose. Both of them put together will reduce weight and uh, uh, hyperglycemia both. And you can break the KG1C paradox here as well. So this is another option that we can use. There are more questions. We thank Dr. Anshul for his polite words. Dr. Armias Gebremichael has asked a topic which is, I know, very close to Dr. Kapoor's heart. So, sir, MAFLD has become too much of an issue, a big issue now. So, how do we deal with fatty liver, or the new term is MAFLD?
Right. So yes, it is a big problem. If you look at the prevalence again, about 20 to 25% of our patients, in general, would have MAFLD. In diabetes, the prevalence goes to 60%. We did a study in obesity, morbid obesity, and it was 80%. So definitely a big problem. So I think the first step is to let the patient be aware that they have fat in the liver, and try and assess the severity of steatosis with the help of simple indices like the FIB4 index that you can use. It's a simple online tool. You just need ALT, platelet count, and the anthropometric measures, and then you will get the score, and you will be able to put the patient at risk whether this patient needs further imaging or testing or not. So I think that is the first step. Management wise, yes, apart from diet and exercise, again, anti-diabetic agents, SGLT2 inhibitors, and GLP-1 RAs have shown good effects. Saroglitazar is another helpful drug which helps to reduce not only the diabetes and the cholesterol, but also fatty liver disease. More recently, newer drugs. There's a drug approved by US FDA just on 14th of this month for specifically management of NASH, which is based on the thyroid receptor physiology. So this is something new, not yet available here, but will be helpful. So this drug is resmetirom. So that is also approved.
Yeah, so Dr. Armias, this is an exciting field. So resmetirom is the drug that is approved, and it is actually a thyroid hormone receptor analog. So it acts on the thyroid hormone partially and helps improve fibrosis or scarring in the liver. One last question, Dr. Kapoor, if you allow. It's past 10 p.m. already, and this again is from Karnataka. Can I start dapagliflozin and metformin together in a newly diagnosed person with diabetes? The gentleman is 37 years old. BMI is 30. Random glucose is 300.
I see no harm in starting together. Like, even as per the ADA or the RSSDA guidelines, we're able to start two anti-diabetic agents if the glycemic control is really poor. I see that is the case. The patient also has obesity, so definitely can start.
And the checklist, any kind of symptom you would want to ask for, any sign you would want to rule out before starting?
Right. I think again, educating the patient, making sure they are not ketotic, they are not having any kind of acidosis, and not having any UTI. So that is something.
If the patient is gentleman, if he has, let us say, melanoposthitis or an active UTI, first we should treat that. After that, we can start dapagliflozin. But first treat the melanoposthitis or the UTI. If the patient has had even a single episode of upper UTI, even a single episode of pyelonephritis in the past, then dapagliflozin is best avoided. With this, sir, I'd like to thank you. Okay, and one question. This is on pragmatic prescription. This comes from Dr. Shashi, and can we advise semaglutide 14 milligram, half tablet a day, or can we prescribe semaglutide 14 milligram every alternate day? Because the daily dose is causing decrease in appetite, patient is feeling unhappy, or the patient just says he cannot afford anymore, but he would like to continue taking the drug.
Right. So half tablet is an absolute no. We know about the absorption of semaglutide through the snack technology. If I break the tablet is not going to get absorbed. So it will be as good as probably throwing it in the dustbin or eating a half tablet. So that's definitely no. Yes, sometimes I have also had to reduce if the patient's tolerability is not good, then taking it alternate day. But still, I must remind the patient that this is how the drug works. It works by reducing appetite, and that's how it's supposed to reduce the weight and glucose. But yes, probably alternate day. If my patient is not able to tolerate for that reason, I may be able to do that, but definitely not give half tablet.
Well said, and of course, ideally you should give every day. But pragmatic prescription means that sometimes the patient takes a drug holiday for whatever reason. We see these drug holidays in other diseases as well, like in osteoporosis, for example. So obesity is then another disease where you might want to think of drug holidays. But with this, Dr. Kapoor, I'd like to thank you so much. You've added so much to our knowledge, our information, our wisdom. And on behalf of everyone who has logged in today, from Ethiopia up till India, we thank you. Uh, I'd like to thank Team FDC as well for all the hard work that they do behind the scenes. And we have Batul who does all the work selflessly for us. But I'd like to hand over back now to Ankur.
Thank you so much, Nitin sir and Sanjay sir, for patiently answering all the questions and give such thought-provoking talk on such an important topic. Now, I would like to thank all the doctors who has logged in on the Sunday evening. Next week again we will be coming up with a new topic with new energy. Thank you so much. Jai Hind. Good night.
Jai Hind.
Good night.